presenting a rare case of recurrent fibrous dysplasia of paranasal sinuses. The 43-year-old male patient has presented to us with a progressive nasal obstruction since last 3 years, a recurrent headache, and open surgery done elsewhere twice before. You can make out the scar of the previous lateral rhinotomy approach. On imaging, there is a ground glass appearance confirming the fibrous dysplasia extending superiorly from the skull base, cribriform, and the fovea. Laterally, it is pushing the orbital wall, medial wall of orbit. Inferiorly, it is touching the floor of the nose as a hard palate and pushing the medial wall of maxillary wall laterally. You can make out the fibrous dysplasia is posteriorly extending up to the sphenoid and the planum sphenoidal. So the posterior wall of the fibrous dysplasia is extending up to the pterygopalatine fossa. We decided to proceed with the surgery endoscopically. Incision has been taken endoscopically, thinking the Denker's approach may be required and the medial maxillectomy in progress. We identified the maxillary sinus, which serve as a landmark. That is the posterior table of the maxillary sinus. Superiorly, we identify the frontal sinus and the posterior table of the frontal sinus as a landmark. Neuronavigation was used during the surgery, which was confirming the position of our instruments. Posteriorly, we identify the sphenoid, and that is also serving as a landmark. The sphenopalatine spurt has been taken care of by a monopolar cautery, and the layer by layer, inferior to superior extent, fibrous dysplasia has been drilled out till we reach the dura. We were anticipating the CSF leak at the end, but leaving the fibrous layer on the dura prevented a CSF leak, and that was confirmed by neuronavigation. The ostia of the sphenoid sinus, frontal sinus, and maxillary sinus are widened enough to prevent the obstructive sinusitis in the future. And this is the cavity at the end of the surgery, and there is no CSF leak. 3 months later, we did an imaging, and there is almost complete excision of a fibrous dysplasia except the floor of the orbit, which was asymptomatic. Here, armamentarium to handle such cases is very important. Endoscopic approach, not only it is aesthetically better, but it gives a very good visualization, magnification, so that you can preserve the vital structures and tackle the complications. By doing external approach, you are blinded at the other end of the tumor. Using angle endoscope, you can have a 3-dimensional approach to the tumor. Armamentarium in terms of the proper skull base drill and the neuronavigation is paramount in this case. Thank you so much.